You can be a vegetarian and have pretty significant atherosclerosis and high cholesterol levels because cholesterol is made in your liver. I mean, the vast majority of it is made in your liver and cleared by the liver with the LDL receptors. So for most people that are at risk for a heart attack based on their family history, et cetera, you're probably not going to outrun that disease risk with just becoming a vegetarian or exercising a lot. So for most people, it's to optimize your health span, so to speak, you're probably going to want to do some kind of medication.
Welcome to the Precision Medicine Made Simple podcast, where we simplify the complex world of precision medicine. We're here to explore how personalized healthcare can empower you to understand and improve your health to live a longer and healthier life. Join us as we break down the latest in medical science into actionable insights. Let's make precision medicine accessible and actionable for everyone. Enjoy the show. Today's episode is sponsored by Biography Health, where healthcare meets personalization. With their DNA-enabled blueprint, Biography Health empowers you with a health plan based on your unique DNA, aiming to prevent disease and extend your life. Take control of your health journey with a plan as unique as you. Visit biographyhealth.com and start your personalized healthcare journey today. As a reminder, this episode is for educational purposes only. This episode is in no way a replacement for professional health advice. Please consult with your professional primary care provider for medical advice. If at any point you feel that a topic discussed on our podcast was misrepresented, or if you have additional insights that could enhance our discussions, we wholeheartedly encourage you to reach out to us. Your feedback is invaluable in helping us improve and in ensuring our content remains both informative and reflective of the latest developments in precision medicine. Today, we're diving into the topic of lipids. Dr. Stanford joins us to explain what lipids are, why they matter, and how understanding your lipid profile can be a game changer for your health. From cholesterol basics to advanced lipid panels, we'll cover it all. We'll explore the latest research discussing genetic factors and examine how lifestyle and medication can impact your lipid levels. Enjoy the episode. Well, I'm excited for this episode of the Precision Medicine Made Simple podcast because as of yesterday, I had an advanced lipid panel and they took so much blood out of me. I was not expecting it, but I do know that there were a lot of different biomarkers that I'm going to be taking a look at once I get the results back. And so I'm here with Dr. Stanford to be able to talk through lipids and what they are, why they're important for our health, and just all the ins and outs of lipids. So welcome back, Dr. Stanford. Thank you so much.
Thanks, Taylor. Good to hear your voice.
I know I feel like it's been so long. But yeah, so I guess like as a first question, and just from my understanding too, can we just dive into what lipids actually mean and why it's important to our health?
Yeah, lipids are an very important molecule in the human body. In a word, lipids are a little bit like a soap bubble, kind of like an oil. If you want to think of lipids being like soap and diametrically opposed to water. So if you want an idea of what a lipid particle would grossly look like, would be like a soap bubble in water, a little piece of grease or oil in water. It's a greasy, oily substance. It's very important for cellular function.
Got it. Well, and so why would you say it's necessary to understand like our lipid panels then? Like what makes them so important?
Well, most of the cholesterol in your body is in your cells. So if a cell was just a lipid bilayer, it would be fairly rigid. But when you have cholesterol interdigitated into the lipid bilayer, in other words, the sphere shell part of the cell, it allows for the cell to have some malleability, some fluidity, and allows for some assist in transport of particles in and out of the cell through channels. So it's also very important in, for example, neurons. So the there's what's called a myelin sheath, kind of like the insulator around a wire conductor that is mostly made out of this, fatty lipid substance. So suffice to say, you need to have, cholesterol is a very important molecule. And by the way, it's also a precursor molecule for, for example, for the sex hormones like testosterone, and which is a precursor for estradiol, so what we call estrogen. So yeah, you got to have it, but the bugaboo in our modern world is that a disease of modern man these days, the most frequent cause of death is atherosclerotic driven coronary artery disease, and also atherosclerosis causes stroke. What's that have to do with cholesterol? Well, with our modern diet and the so-called standard American diet, SAD diet, you can have an accumulation of cholesterol in the artery wall. And this is not good, as it's very inflammatory. It can lead to narrowing of the vessel. So you can imagine if you have a circular vessel and this cholesterol starts accumulating on the inside of it, it narrows the caliber. But even more importantly, if one of those, if the inner wall were to rupture and allow some of that plaque into the bloodstream, it's very thrombogenic, causes a clot, cuts off blood supply from that point on. If that happens in your heart, they call it a heart attack. If it happens in your brain, it's called a stroke. So what our challenge is in modern medicine is how to keep that from happening, to how to keep the cholesterol from oxidizing and accumulating in the artery wall, and how to stabilize plaque that is in your body so that's in your arteries, that's lining your arteries, so that it doesn't rupture and cause a clot and a distant infarction from that point.
This is going to be a really granular question because I'm curious as how the good cholesterol, so the HDL, and then the bad cholesterol, the LDL, like why doesn't the good cholesterol clog up into the cell membrane versus the LDL, which I guess clogs up in the arteries then? Like, is there anything specific as to why that
first of all,
happens?
the term good and bad cholesterol, some people don't like it referred to like that, because what you're really talking about is an HDL, high density lipoprotein particle, being the so-called good particle, and the LDL, the low density lipoprotein, being the so-called bad particle. The cholesterol in both of them is exactly the same. What's different is the role that the HDL particle plays. That's why HDL is good, LDL is bad. So LDL particles tend to get, if they're small and numerous, they tend to infiltrate into the artery wall, where they're then scavenged by macrophages, which are part of our immune system that scavenges things from where they don't belong. For a variety of biochemical and pathophysiologic reasons, those particles can get stuck in the artery wall, leads to inflammation and this cascading of bad events that results in a atherosclerotic plaque, we call it. And if you want to think of a plaque, again, I didn't do a very good job explaining this at the top of the interview here, but think of it as these accumulations of oxidized cholesterol and this inflammatory response that is being mediated somewhat by these macrophages, these scavenger cells, as being almost like a blister. So if you think of a pipe and you think of, a blister, we've all eaten hot pizza and had little thin
Blisters in our
walled
mouth.
blisters occur on the top of our mouth. It's really as simple as that, but instead of lymphatic fluid or serous fluid that you have in that little pizza blister on the roof of your mouth. This is lipid filled, and you don't want that plaque to rupture. So when the covering, so to speak, of the blister is very thin and friable because of all the oxidation and inflammation going on in there, that can lead to plaque rupture and again, infarction of the tissue distant to that.
And that comes from the foundation of just these scavenger cells from the LDL. Am I understanding that correctly?
Right. So my point that I was leading to was that LDL particles are particularly good at infiltrating into the wall, and that's why there's so-called bad particles, and the HDL particles, the so-called good particles, are good at retrieving cholesterol from the artery and bringing it back to the liver.
And something that you mentioned from like a previous podcast as well, because it almost blew my mind and how you were explaining this. You mentioned that it's how our body creates the cholesterol in our body. Just because you've had patients
Yeah.
where they were vegetarian or they were vegan and they technically weren't eating any so-called, I guess, food with high cholesterol or bad
Yeah.
cholesterol. And so there's just common misconception then that can impact your
Well,
LDL. Am I correct?
and let's be clear. So, I probably have had a habit of overstating this in the past that what you eat, has quote nothing to do with your cholesterol levels. That's not entirely true at all, or your tendency toward atherosclerosis. It's just that the vast majority of it has to do with your genetics and the cholesterol that's manufactured in the liver and cleared by your liver, the LDL receptors. So you can have a terrible diet and have very high triglycerides, for example, and that can be, atherogenic. And certainly if you exercise, you're going to increase those good HDL particles. And so that's favorable. I think that the point is that as you allude to, you can be a vegetarian and have pretty significant atherosclerosis and high cholesterol levels because cholesterol is made in your liver. I mean, the vast majority of it is made in your liver and cleared by the liver with the LDL receptors. So for most people that are at risk for a heart attack based on their family history, et cetera, you're probably not going to outrun that disease risk with just becoming a vegetarian or exercising a lot. So for most people, it's to optimize your health span, so to speak, you're probably going to want to do some kind of medication.
Well, and that brings me to another point too, because you mentioned, and this was offline, and I was very intrigued with just these two in particular that I believe are inherited. So correct me if I'm wrong, but I have so much trouble saying this. Familial hypercholesterolemia,
Familial Familial hypercholesterolemia.
cholesterolemia, and LP(a).
Yeah.
And so I was wondering if I can get more insight on those because they will. I've okay. How do I break
So
into this?
familial
Yeah.
hypercholesterolemia basically gets at mutations in the LDL receptor on the hepatocytes, the liver cells. So one of the functions of the liver and these LDL receptors is to clear LDL particles, those small atherogenic particles from the bloodstream, and therefore, if you have lower concentrations of it, and there's less tendency for it to infiltrate into the artery wall and create an atherosclerotic plaque. Those LDL receptors, there's a number. I want to say I've seen numbers as high as like 2,500 different mutations you can have in that very large gene that makes that fairly large protein product that is the LDL receptor. Certainly, there's some common ones, and certainly any mutation you have that seriously affects the function of that LDL receptor, that mutation can follow an inheritance pattern, and it can result in a familial pattern of heart attack and stroke. The lipoprotein a that you referred to, that the gene that produces that product can also have variations where some people make more than others, suffice to say.
And this is what's really intriguing, because on that previous episode where we were doing my blueprint and we were looking through my polygenic risk scores, I had a higher genetic predisposition for high Lp(a), and that's also what dictated me to go get an advanced lipid panel then.
Right.
And so, I mean, correct me if I'm wrong. I mean, with Lp(a), is there any, and I guess with familial hypercholesterolemia, oh man, I'm totally butchering the name. Like, is there any
You can
lifestyle
just say
factors?
FH if you want.
FH, okay. I'm just gonna go FH this time because I'm still having a trouble just saying it. But so with FH and then Lp(a), are there any lifestyle factors that we can do to try and bring that down, or just prevent?
No, I mean, the usual things that will have some favorable impact in terms of lifestyle, certainly being careful to monitor your diet to avoid high triglycerides and crank up your exercise levels will help with the background. But specifically, there's nothing that you're going to do with your lifestyle that's going to change your genetic makeup per se. And so that is going to remain a problem. And you're probably not going to, outrun the disease just with lifestyle factors alone.
And I'm not gonna lie, that's kind of scary because, and this is going to be discussed in a future episode, especially when I do get the results. We go over my results from
Right.
that lipid panel, because like my grandmother had a heart attack at 64, and then actually my uncle just had a heart attack at 61 just like a few weeks ago. And
Yeah.
everybody on my dad's side,
Terrible.
yeah, everybody on my dad's side has not made it past 64. And so now I'm like
How old's your
curious.
dad?
Well, he's going to be turning 60 in October. And so well, he was like, hey, it was such a bad joke, but he's like, I have 4 years left to live. But I'm like, no, Dad, you're still healthy. But I don't want him to think like that. But I am curious though, if some of this has to do with genetics.
Absolutely. It sounds like there's a, familial pattern of it. Our discovery in you that you have a gene variant of lipoprotein a that causes there to be high concentrations of lipoprotein a in your body is certainly worth aggressively pursuing, not just for you, but obviously for your dad. We need to look at him. Turns out that it's very difficult to decrease lipoprotein a right now. And let me expand on that a little bit. But suffice to say that lipoprotein a is just one part of the problem, just like your, PCSK9 function is one part of the problem. Your propensity to have a large number of small LDL particles is part of the problem, et cetera. It's just that the lipoprotein a is definitely one that, I know some lipidologists that, and by the way, I am not a lipidologist and I am not a cardiologist. This is, kind of internal medicine, general practitioner level knowledge I'm spitting here today. So, with lipoprotein a, things like PCSK9 inhibitors do a better job than statins. Statins, from my knowledge set, doesn't really lower the lipoprotein a much, but it does lower LDL and it does modify some of those other things. So that's favorable, but PCSK9 inhibitors like Repatha, for example, will lower the lipoprotein a like up to 20% from what I understand. And there are some very exciting new medicines in the pipeline that are what we call small interfering messenger RNA. I know that's pretty esoteric there, but suffice to say, there are some medicines in the pipeline that show a lot of promise and appear to be safe, kind of expected to be approved in the next several years, that will severely impact the ability to make lipoprotein little a, which is a good thing in someone who's making way too much of it.
Yeah, and I have a feeling. Yeah, I have a feeling I'm making way too much of it, and I guess we'll find out when the
We're gonna
results
find out. But
when the
yeah, I mean,
results
all
come
worried
out.
about your dad now too. So has he had his lipoprotein little a or ApoB or any of those, or has he just had standard lipid panels? Does he know anything about his heart health?
No, I don't know if he knows anything about his heart health, but he has, I mean, he's been looking at just his own doctor, I think, with Kaiser, and he just does his routine physical and his routine checkup. They said everything looks good. But I, yeah, he said
Yeah,
everything.
everything doesn't look good if you have that family history until you have
Oh,
looked a
until
hell of a lot
it's,
closer. Then it sounds like they may have looked so far. So yeah, maybe
yeah,
have them give me a call, as they say.
I would love to. And also he's a UCLA grad too. So I think he too can
Well,
definitely
that
bond over that as well.
well, that's
Um,
definitely a favorable prognostic indicator right there. Hello,
er,
Bruin. That's
oh,
good stuff.
Bruin. Yeah.
Yeah, no, because so the way that this is just a classic example of, personalized precision medicine. So personalized, you know, we have figured out that we figured out by family history and by your personal genetics that you probably have some increased risk of heart disease, as well as your father. And when we look at your genetics, we see that the reason for that might be, high production of lipoprotein little a. What's exciting about that is we now have a target. And as I said, well, I mean, the first is identifying that you're at increased risk. That means you can't go Kaiser on it and say, you're looking good, sir. Can't go with that. We have to take a closer look at really what that lipid profile looks like, including lipoprotein little a and apolipoprotein B. And I'm going to predict that I'm going to recommend getting a coronary calcium score. Most probably, actually, for him, I would go straight to the coronary CT angiogram.
CT angio.
We're not talking tens of thousands of dollars here. It's a test that costs, $500, $600, $800, depending on where you are. And that kind of knowledge of knowing that you have a heavy atherosclerotic burden will spur cardiologists to, become very aggressive. Does he even have a cardiologist?
I don't know. I should probably ask that question. I don't
Anyway,
think so.
we're probably violating all kinds of stuff HIPAA-wise with your dad, but uh,
Well,
yeah.
well, I mean, well, I mean, we're
Well,
not
actually,
really,
we don't know anything about your
we
dad other
still
than
don't,
you
yeah,
have a dad. It's your uncle that passed away last week, and
yeah.
and what'd you say, your grandfather or
Uh,
grandmother?
grandmother, yeah, she passed away. Well, maybe that was a while ago from a heart attack too. But I mean, but it's sparked up a lot of questions, and it's, I mean, in the fact that we're having this conversation about lipids, it almost makes sense as to why you recommended me to then get my lipid panel and just all my different
Yeah.
tests done. Now, I mean, why?
Can I circle back to the, why this illustrates the paradigm of personalized precision medicine.
Yeah,
So
yeah,
yeah, so we look at your family history and we see risk. We look at your personal genetics, we see risk that might explain the family history. And then in terms of precision medicine, probably every patient doesn't need their lipoprotein little a checked all the time. For example, I've checked mine. It's very low. It's very low for genetic reasons. No credit to me. And, but I don't need to check it again, right? Because that's it. So, so personalized means we figure out what it is that makes Taylor in terms of genetics and what makes you an individual. And so we need to individualize you. We need to really, the term you use, do some fine granulation on you to see where your risks are. Once we identify the risk, we can do precision application of tests that reflect the science of today. And we're going to go from there. And we're probably, for your dad, maybe not for you right now, but we're probably going to want to do a coronary CT angiogram. But for you, with this family history, and if we find your lipoprotein little a is high and your, and your lipid profile is just kind of unfavorable, we're going to want to start medication on you, even though you're what, 29 or 30 or something. How old are you?
29, not 30 yet. 30 in February.
29 and holding. Well, most of the country is 29 years old. Everyone wants to just hold at 29. So
Well,
this is the time of your life. Anyway, go ahead.
I read somewhere though that if maybe it was actually you that sent me the article where it was now more common to have people at a younger age start on statins of some sort then.
Yeah, I think I was referencing Harvard trained cardiologist. He did a webinar for Allelica the other day, which is a company that does polygenic risk scores. And I noticed that the same guy, the same preventive cardiologist, is doing a webinar for the Clearly company, which that's Cleerly. Don't work for them, but they have an amazing product, which is software that can be applied to a coronary CT angiogram and give very specific information about the types of plaque that are present, in terms of, are they calcified and stable? Are they unstable and, full of inflammation and at high risk to rupture? That stuff, can be predicted based on AI algorithms. And anyway, the same guy is giving a talk for them coming up at the end of the month, end of July here,
Nice.
and very clearly. And I don't know, maybe that's all he does now is give webinars. No, I'm just kidding. But anyway, with his first webinar, and I know lots of, Peter Attia, lots of people I think would follow this philosophy, is that atherosclerosis really starts in the late teens and 20s. And if you know someone's at risk, why wouldn't you just start addressing that risk now? Why this is the beauty of personalized precision medicine, because it's proactive. Why wouldn't you proactively interrupt that process as you're transitioning from this time of health to chronic disease? Atherosclerosis is a chronic disease. You would want to intervene as soon as possible, especially if it's the most probable thing that's going to take you out in your 60s, 70s, or 80s. So why wouldn't you would want to get to your 90s with clean pipes, right? And if you do, you're liable to have a pretty functional decade there in your 90s. And that's really what we're trying to do, is delay the onset of chronic disease, intervene at the very earliest transition from health to disease, so that you can be as functional as possible in the last couple of decades of your life, and not be one of these people, that unfortunate people that have had heart attacks and strokes and are completely debilitated and have minimal quality of life in terms of your functional status for the last couple of decades. So we're trying to meaning people that are advocating for personalized precision medicine, are trying to gain you another 10 or 20 years of highly functional life.
I have to say, I'm definitely grateful and honored to be able to come onto this podcast and be able to speak with you and working with the team too. And considering we've been friends for over 2 years now.
The check's in the mail.
Yeah. What bit, now backtracking then, I mean, and this could potentially be such a dumb question, but maybe it's an obvious question, but why, at what age do people usually get their lipid profile checked? And do people usually get their lipid profiles checked just when something they feel like goes wrong,
Oh,
and
I
then
hate
that's
when you
it?
ask me board questions. Uh,
Oh, jeez.
so I think that the guideline recommendation is to certainly check it by age 18, maybe, yeah, I think maybe 18 or 21. And then every year or two after that. So one of the problems with these guidelines is they were derived even just 10, 15, 20, 25, 30 years ago. Medicine was a completely different sport back then. Now we have so many more tools and so much more understanding that I wouldn't go by traditional guidelines. So I'll give you my own guideline. I would certainly check anyone by age 18 if you see something really abnormal, like a total cholesterol of 300 and a LDL of 200 or something crazy like that. You're going to want to refer them to, or and take a close look at them from a lipid management standpoint very early on. Family history is going to drive a lot of it, and quite frankly, what this looks like 5 or 10 years from now, once personalized precision medicine has really taken hold, I'm not exactly sure. I would not be surprised if 10 years from now, the guidelines may dictate that you be very aggressive early in the 20s with someone that has a strong family history, unfavorable genetics, and an unfavorable lipid profile in your 20s. I would start treating it then. I think that that's what will be de rigueur 10 years
Mm,
from now.
moving forward then. And I mean, is it, if you were to go to your doctor and then request that I would like to I would like to get my lipid profile. Like, I mean, would they be pretty receptive of it, or would they say like, "Why would you need that?" Or would like, what was the? I'm just curious what that conversation would look like because I wouldn't have
Yeah,
asked it if you
I
didn't
have
tell
to tell
me.
you, I'm a little out of touch with well, I'm not that out of touch. I think very few uh, doctors, I'm going to say fewer than 20%. I'm going to give them the benefit of the doubt and say uh, maybe 20% of doctors will check an advanced lipid profile to give you information on lipoprotein little a, apolipoprotein B, which is basically an indication of badness in terms of the LDL function, et cetera. Apolipoprotein B is the lipoprotein that ultimately leads the LDL and other particles to stick in the artery wall, et cetera, without getting into a biochemistry lesson. But yeah, I think I think probably a fair number of cardiologists will do that. You may have to just ask for it. I don't know. I don't
Mm,
know. I will tell you that the good news is that Quest, well,
yeah,
Quest.
I just
Um,
did. I just got my thing from Quest.
forget Quest.
Oh,
Yeah, sorry, forget Quest for a second. I really meant to say most insurance companies will pay for an advanced lipid panel with no question.
okay, good to
So
know.
they know.
All right, all right. Yeah, because I just went to Quest. That's where you told me
Yeah,
to
no,
get.
and I only mentioned Quest. Most doctors use Quest and LabCorp a lot because they're ubiquitous and they're whatever. They're the big labs, and they both have advanced lipid panels.
Yeah. I mean, well, shout out to shout out to Quest over in Sacramento. It was a very smooth and quick and easy process. They took care of me and took a lot of blood, so it was good, and it was a very smooth process. It didn't even hurt, so it was great. Shout out to them. Now, and I might throw you off with this question, and this could be a loaded question here, but is there like a top 10 list of lipids that you should be looking at, like in terms of just
Yeah, so
what you should pay attention to?
so I think most of us have seen a lipid panel on our lab results, and the standard lipid panel is total cholesterol, low density LDL, low density lipoprotein or LDL, HDL, triglycerides. The calculation is you can calculate your LDL levels based on your total cholesterol minus the HDL minus, in parentheses, the triglycerides divided by 5. That's your LDL calculated. In order for that to be accurate, you have to be fasting. The reason you need to be fasting is you want the triglycerides to be the right, to reflect a fasting level. So if you're not fasting, you can still do it, and you can get what's called an LDL direct. So they can directly measure the LDL instead of calculating it. But your triglycerides will be off if you've eaten.
Okay.
But you wanted the top 10. Okay, so the next thing you definitely want to look at is the apolipoprotein B.
Okay.
And you want to look at, and it's usually pretty well tracks with LDL. Again, I'm not a lipidologist, so if there's someone out there going, I know an instance where it doesn't, but generally it
General
tracks with
info.
LDL. And of course, this lipoprotein little a, again, if you measure it and it's high, it's up near 80, 90, 100, 120, something like that, that immediately gets the attention of anyone that knows what they're doing when they're looking at lipids. Same with apolipoprotein B, if that number is up into 120s, 130s, same with LDL. So you want to be looking at a standard lipid panel and the lipoprotein little a and the apolipoprotein B. On the Quest panel, they also have this cool feature where they subfractionate the LDL particles, because there's very low LDL and not so low LDL, and they actually tell you the number of the HDL particles and the size of the LDL particles and the number of the LDL particles. So very key, and they'll actually give you a grade, A or B, A being favorable, B being unfavorable. So in terms of LDL particle and particle size and number, and HDL particle number, et cetera.
Got it. And okay.
So, I mean, so to answer your question, if you want to understand your lipids, most doctors can understand an advanced lipid panel. And again, you look in the context of the patient. So is their family history? What's the age of the patient? What's the what is the pattern of lipids? Is the total cholesterol may be high, but that may be because the HDL is high. Are the triglycerides high? Well, that's a little different question and approach than if the apolipoprotein B is high or lipoprotein little a is high. So again, in the right hands, that can be very valuable information to prevent probably the most important adverse, easily prevented pathophysiologic process in your body, and that is atherosclerosis. It affects your brain health, it affects your heart health, it affects your sexual function, it affects your peripheral nervous system, if you your balance, et cetera, coming out of your feet. If you tend to have small vessel disease, we've all heard of peripheral vascular disease, and we know that leads to peripheral neuropathy, which can affect your balance. So if you're going to get one thing right, it is keep your pipes clean. We know how to do it.
Just get it checked.
Just got to get it checked, and hopefully you have a proactive doctor that's willing to do something about it.
Is there ever a case where I guess you shouldn't check your lipid profile? I know that's probably really silly, but I feel like
I gave you one example. So if your lipoprotein little a is low, like less than 10 or undetectable, you don't need to check it again. So there's that. I think you generally want to check it
anyways,
yearly. And you certainly would want to check it a few months after you change therapy. So
therapy meaning like if you're on a statin and then you want to check your results to see if it's gone down or not, to see where you are.
Yeah, I have a patient that recently increased his statin, and because we didn't get the movement in his LDL and apolipoprotein B with the initial dosing. So we increased the dose, and we need to see the effect of that.
Oh, good to know. So closing out this episode, then, any actionable advice that we can give to our listeners first steps if they just want to if they want to improve their lipid levels and lipid profile?
Yeah. So I I don't know what famous person said this. I almost attribute everything to Bill Gates, and then someone goes, "No, he didn't say that."
We can
But
attribute it to Bill Gates this time.
or Ben Franklin. So I'll attribute this to Benjamin Franklin. I know
All right.
it's neither one of those guys. I'm
Okay.
playing with you, but if you want to affect something, you have to be able to measure it. So the first step is just measure it. And also the cool thing along these lines, and I know I've mentioned this concept before, and that is your family history. So it's one thing that you share genetics with your family, but what's great is you have parents and grandparents, and you can see how those genetics, played out. And I don't know if any of my brothers or sisters listen to this podcast, but I have 5 older brothers and sisters. So I've got my own little laboratory right in my family, so and 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 really it has been kind of amazing for certain things that, so and so will say, yeah, my I needed reading glasses at 42 and a half. And then sure enough, for me, I need reading glasses at 42 and a half, so and there's a lot like that. I had my first basal cell taken off at age 45, and you go, anyone have a basal cell? You're at the family reunion. They go, yeah, I had one taken off when I was 45. And so you can tell a lot from your family history. And I know I've mentioned Lori Orlando at Duke University. She's a professor of internal medicine there and director of the precision medicine department there. They actually have a precision medicine center. And she has developed algorithms based on your family history that will actually give you a risk score, just like I think have we had an episode on polygenic risk scores yet?
Only from the presentation that we were going through, but I think that could definitely be another episode specifically on polygenic risk
But
scores.
anyway, like with polygenic risk scores, we assess risk. We say you're 2 times average risk, 2.5 times average risk, less than half average risk. So so these, the bioinformatics and AI and algorithms are able to compare your genetic profile to others that have gone on to develop disease or not develop disease and predict your future risk of these chronic diseases. Well, Dr. Orlando has worked out algorithms where she's able to do things like that just with the family history. So with Biography Health, we're looking at, adding to our ability to analyze risk by incorporating that, not just family history going, oh, you have a lot of family history, but quantifying it like she's able to do with her, it's called the MeTree app. Again, not paid by Dr. Orlando, Duke, or MeTree, but I think that's pretty cool. And as I said, in a Bayesian way, you kind of layer all these risks and look at each new piece of information in the context of your prior credence, your prior estimation of risk, and it allows you to hone it that much better. And going forward in this age of AI, I mean, you can imagine 10 or 15 years from now how probably eerily accurate, and I think it's a great thing, that we will be able to predict how your health risks play out as you proceed through your life. And why is that important? Because we look at those areas of increased risk, we do increased scrutiny, and maybe we don't do the standard one size fits all population scale thing for everybody. Maybe we individualize it and we go, look, you have a significantly increased risk here. Let's take a closer look, mitigate that risk so it's down closer to average or less than average. And we can do that. I really believe we can do that with the vast majority of, the vast majority, but right now with many of the important conditions like heart disease, diabetes, probably even neurodegenerative diseases like dementia. I'm sure neurodegenerative diseases such as dementia and Parkinson's, I think you can most likely impact that risk through lifestyle and making sure you get to sleep and exercise and eating and not being diabetic, not being obese, blah, blah, blah. Same with your cancer risk.
Yeah. Well, and that brings up a good point too, is because I remember you were mentioning that you had a very close family friend that is developing a vaccine for Alzheimer's, right? But you mean you mentioned dementia,
Yeah,
right?
that yeah, so there's a company out there called Takeda that no, I don't know anyone personally working on that project, but two of my friends work at that company, which has acquired the rights for potential. I think I said 3 billion when I told you before, but I was at dinner with them the other night and we looked it up. It's 2.2 billion
Ooh.
that they may ultimately pay if they're successful at developing an Alzheimer's vaccine. They've acquired that company, that technology. I think they paid 100 million for it outright, but that price that they paid will go up. Kind of like when you trade, you're in the Dodgers and you trade for a pitcher, and if if they make the All-Star team, you have to pay extra money to the team you acquired the player from, or if they win 20 games, then it's going to cost you another 20 million and you have to pay to the old team. So it's a little bit like that when we're talking about Takeda, betting on the come with this Alzheimer's vaccine.
Cool. And you also mentioned, I guess now we're just like speaking the future of lipid management.
We're
too.
just spitting.
Well, because I also remember
we're just spitballing.
We're spitballing. Yeah. A drug, you mentioned there's going to be a drug for Lp(a) at some point too, right?
Yeah. So if you think back to some of the earlier episodes, I talked about the central dogma of biology. That is, you start with DNA. That DNA is a strand. A molecule lands on it called RNA polymerase, rolls over and actually generates a messenger RNA. So it transcribes that DNA into a messenger RNA. And that messenger RNA then, through some cool intracellular machinery, is made into a string of amino acids, which folds up into a protein. That's the central dogma of life. And so an interesting class of drugs are these small interfering messenger RNA. So we say we transcribe that DNA into a messenger RNA. So now you got this messenger RNA strand. And if you give and so it's, A, T, C, U, T, whatever. I get
Right.
C, G, A, U, I guess it is. They don't have T's in messenger RNA. But if you were to put a complementary strand on it, you would then block it, right? And so now that can't get translated into the protein product. So the thing for apolipoprotein little a is that they're going to have they call them small, they call them antisense oligonucleotides. So oligonucleotides just means a strand of those letters. And if the RNA is sensed, the antisense binds to it and thereby blocks it. And so apparently there's a pretty effective one in the pipeline. Just listening to a podcast, I can't remember who it was, but they talked about very promising, very advanced in the development, these antisense oligonucleotides for lipoprotein little a. So there's hope for you, sir.
That's all I wanted to hear. That's what I wanted to end this podcast with.
And actually, I just can't overstate how really in the span of my 35-year career in medicine, how we are accelerating in the development of new classes and of drugs and the effectiveness. It's just completely mind blowing.
Wow.
And it's just getting
started.
I mean, it's just getting that that tech curve, and that is just accelerating. It's just getting steeper and steeper. And that's really awesome, for now, right? I mean, we are going to, untangle these pathways of disease, and AI is going to drive drug discovery like you wouldn't believe. You're going to be able to use AI to predict whether certain drugs that already exist, different applications of it, and designer drugs are going to say, we need a drug that looks like this, that does this. AI, tell us what we should do to build that. And it will, and it's a bit of an oversimplification, but, these are exciting times. And those people that are out there boldly predicting the end of illness, like I saw, Sanjay Gupta is a guy on CNN, he's the neurosurgeon. Anyway, he said the last Alzheimer's patient, and then Dale Bredesen, also a leading expert in Alzheimer's, he wrote a book, The End of Alzheimer's, David Agus, The End of Illness. We're approaching a time where we can prevent these chronic diseases like never before, like you couldn't even imagine. And it's coming fast, and it's coming hard. And then the real tantalizing thing there, which I think is a heck of a long way off, but is out there, is, aging is really kind of a chronic disease, if you will. So in other words, it's, certain things that happen in the course of normal cellular physiology that you would rather they didn't happen. So if you have enough knowledge around that, again, if you can measure it, you can, intervene on it. You're not going to be able to tell how effective your intervention is if you can't measure it. But likewise, you can't intervene on something really effectively if you don't know what the pathways are. But we're figuring out those pathways at light speed, not just for aging, but more importantly, in the near term, for things like cancer and atherosclerosis.
Wow, I love it, and it's empowering too, right? And it goes back to just,
oh yeah, I mean,
it's like the future.
I mean, it's all good news. It does. So I'm going to plug a book. I'm not going to remember this guy's name, but everyone's going to think I watch CNN all the time. I do not, but my wife does. But Fareed Zakaria recommended this book called The Longevity Imperative. And I'm really blanking on the guy's name. He's from the UK. But anyway, there is this element of delaying the onset of chronic disease and people living longer health spans. We'll forget whether or not we can actually, I mean, let's just assume that the effective lifespan is 85, 95 years old. But what we're going to do is people are going to be functioning at a high level, all the way through their 70s and 80s and into their 90s, and hopefully be functioning at a relatively high level when they just go meet their maker after going to bed one night after playing a soccer game, a pickup soccer game in the neighborhood at age 93 or whatever. So, but that's going to drive a lot of societal changes that need to occur, and et cetera, and planning for the individual. And so the longevity imperative, it's a great book. It's a fun listen.
Yeah, I'll check it out. Yeah. Thank you so much, Dr. Stanford. Well, awesome. This was a very informative episode. I liked that we got personal too, and also left me with hope and empowerment. So like,
well, I can't wait to see your lab. So when did you get them drawn?
Yesterday.
So that lipid panel by Quest usually takes about 7 days. So yesterday is Wednesday. So
Wednesday, recording.
So
the
plan
24th.
on talking to me next Wednesday. Oh, maybe we'll do the next podcast. We'll go over your labs with you, and I'll tell you how we're going to make it so you have clean pipes at age 95.
Let's do it. Can't wait. Awesome.
Hey, thanks for having me on.
Thanks for joining us on the Precision Medicine Made Simple podcast. If this episode inspired you to learn more about your health, please leave us a review and share the podcast with a friend. Your feedback helps spread the word about the power of precision medicine. Remember, taking action today can lead to a healthier tomorrow. See you next time.